Next up is Dr. Liu from Beth Israel Deaconess Medical Center, looking at the effect of symptom time and type from symptom onset following carotid endarterectomy.
Thank you for the opportunity to present our study. I'll be presenting the effect of symptom type and time from symptom onset on outcomes following carotid endarterectomy. Since the introduction of carotid endarterectomy in 1954, it's been an established method for carotid revascularization in symptomatic and asymptomatic carotid stenosis. Currently, symptomatic patients are defined as patients with neurologic symptoms within 180 days, which has largely been based off of the large randomized trials, such as NASCET and ECST, which utilize 120 days and 6 months, respectively, as the definition of symptomatic carotid stenosis. While there have been studies looking at outcomes based on time since surgery, much of the focus has been on early intervention, and there have been a few studies that analyze the outcomes on patients who have previously had symptoms greater than 180 days compared to never symptomatic patients. However, some of their results have differed. Therefore, our aim was to use a large nationwide database to investigate the influence of time since symptom onset and type of symptom on stroke and death after carotid endarterectomy. We utilized the BQI from 2003 to 2019 and excluded those where we could not determine the surgical side, whether the patient had vertebrobasilar or nonspecific events, concurrent CABG or emergency cases, or other essential missing data. And from the total 121,977 patients, we had a cohort of 74,606 patients, which we split into recently symptomatic, formerly symptomatic, and asymptomatic. And then within those cohorts of symptomatic patients, we divided them further by symptom type. We defined recently symptomatic patients as symptoms within 180 days, formerly symptomatic patients as symptoms greater than 180 days, and asymptomatic as those who had never had symptoms prior. Primary outcomes were 30-day stroke or death. Secondary outcomes were cardiac complications, return to the operating room, surgical site infection, or reperfusion. When we took a look at our overall demographics and comorbidities, formerly symptomatic patients were least likely to be white, most likely to have hypertension, diabetes, heart failure, and renal dysfunction. Formerly symptomatic patients were also most likely to be on anticoagulation and statin therapy, but was intermediate on the use of aspirin and beta blocker, as well as the ACE inhibitor. Formerly symptomatic patients had longer operative time than asymptomatic, but similarly to recently symptomatic. And recently symptomatic were least likely to undergo elective CEA, whereas asymptomatic were least likely to require general anesthesia. And then looking at overall secondary outcomes, recently symptomatic patients had higher rates of cardiac complications and return to operating room than asymptomatic patients. There was no real difference in SSI or reperfusion amongst these three groups. When we looked at the 30-day outcomes by time since symptom, overall, recently symptomatic patients had the highest rate of stroke or death at 30 days, at 3.6% versus 2.6% in formerly symptomatic patients and 1.8% in asymptomatic patients. There was a significant difference between all three groups. When we corrected for differences amongst the groups and looked at the odds of stroke or death based on time since symptom and symptom type, we found that patients that had presented with stroke had the highest odds of stroke or death at 30 days, compared to asymptomatic, with all groups of symptomatic having had higher odds of stroke death compared to the asymptomatic group. Recently symptomatic had the highest odds of stroke or death at 2.08, with formerly symptomatic having an intermediate odds of stroke or death at 1.44. When we looked and broke down by the symptom type, within the stroke cohort at 30 days, the recently symptomatic patients had the highest rate of Stroke or death at 4.1%. Formerly symptomatic had 2.8%, and asymptomatic was 1.8%. This was again significantly different between all three groups. When we looked at the odds, the recently symptomatic patients had a 2.39 odds of stroke or death compared to asymptomatic, and formerly symptomatic had a 1.57 odds of stroke or death. For the TIA cohort, the recently symptomatic patients had a 3.9% rate of stroke or death compared to the 2.6% in formerly symptomatic, and again the 1.8% in asymptomatic patients. And while the trend rates were similar to the stroke cohort, the only significant difference that we found was in the recently symptomatic versus asymptomatic group. When we looked at the odds, the recently symptomatic patients had a 2.24 odds of stroke or death compared to asymptomatic. Formerly symptomatic patients had a odds of 1.44, which in trend was again similar to the stroke patients. However, it was not statistically significant. When we looked at the amaurosis group, the numbers were much smaller. However, again, the recently symptomatic patients had a higher rate of stroke or death at 2.2%, formerly symptomatic at 1.7%, and asymptomatic again at 1.8%, with no difference between the formerly symptomatic and asymptomatic groups. When we looked at the odds of stroke or death, the recently symptomatic again had higher odds at 1.32. However, the formerly symptomatic was not any different from the asymptomatic within the amaurosis group. We then did a Kaplan-Meier analysis of freedom from stroke or death for each time cohort within all patients. And we noted that the formerly symptomatic group, which is in red, had a significantly lower freedom from stroke or death compared to asymptomatic. And it was much more similar to the recently symptomatic group. We noticed a similar trend when we did the Kaplan-Meier analysis for just the stroke patients, suggesting that the overall trend is primarily driven by stroke patients. When we looked at the TIA cohort, we actually noticed that recently symptomatic is the only significantly different from the asymptomatic patients. When we looked at amaurosis, there was no difference in freedom from stroke or death in actually all three groups. So, in conclusion, based on our data, patients presenting with stroke greater than 180 days prior to elective CEA are at an intermediate stroke or death risk compared to recently symptomatic and asymptomatic patients. Patients presenting with TIA or amaurosis greater than 180 days prior did not have any significant higher risk of stroke or death when compared to asymptomatic patients. Thank you, and I will take any questions.
Thank you. Great presentation. So this is from Dr. Sukau. The VQI captures outcomes at hospital discharge and at 1-year follow-up. That means that post-discharge strokes won't be caught until 1-year follow-up, which has notorious poor compliance. How confident are you that VQI, hold on, accurately captures all strokes within 30 days?
Yes, so that is a great question. I think that is probably the biggest issue with the VQI, again, is that there is poor long-term follow-up, and it does not necessarily capture all of the strokes at 30 days. However, the similar trends can be seen, at least in hospital stroke perioperatively as well. So I do think that we can at least take this data and still gain some knowledge as to the differences between these groups.
Thank you. And so you defined formerly symptomatic after 180 days. Did you look at any other cutoffs, 6 months, 2 years, where there was where the formerly symptomatic looked more like asymptomatic versus more like the recently symptomatic?
Yeah, so we actually did try to take a look at if the further out after 180 days, if they started to have risks that were closer to asymptomatic patients. However, this just the way that the patients split up after greater than 180 days, they actually had patients all the way out to like 10 years prior had symptoms, and there were very kind of few patients in every single group thereon after that. And there was never any particular, like grouping that we could make that would make the patients have a similar risk compared to the asymptomatic.
Excellent. Next question is from Dr. Black. Does VQI capture hematoma? And he points out that most acute stroke patients are loaded with 600 milligrams of Plavix. Could that explain the return to the operating room? And then a follow-up question, can you eliminate those who return, i.e. a stage CEA/cabbage?
So in terms of the first question, so it does at least state whether or not the return to the operating room was related to bleeding or whether it was related to a neurologic event. However, I did not specifically take a look at the reasons for return to the operating room. So certainly that could be a possibility and something that we can look into. And I'm sorry, if you could just repeat the second question.
It had to do with distinguishing or looking at a subgroup analyses of patients that underwent concomitant CEA and cabbage.
Yes, so we actually specifically excluded those patients within our cohort because we wanted to look specifically at just patients who were being treated for carotid stenosis, symptomatic carotid stenosis.
So with the data that you presented, the very compelling and interesting data, should our society develop practice guidelines for management of formerly symptomatic patients?
Yeah, so I think, it comes down to also knowing what the natural risk is going to be for these patients, greater than 180 days out, if they're 1, 2, 3 years out since their stroke and they are found to have this carotid stenosis, what is their actual natural history? What is their true risk? If it is, similar to an asymptomatic patient, then we can better give them their operative risk, which does seem to be that they have a higher operative risk than if they were a regular asymptomatic patient, and how much benefit they would be getting from having a carotid endarterectomy.
Great, thank you so much.